Hello, everyone. This is Adedayo Adio. I'm speaking to you from Nigeria, and we also have a guest all the way from across the world. And we're going to be talking to you today about management of retinoblastoma. It's important for us to give you a brief background of who we are. We are a society of all pediatric ophthalmologists, and I'm chairing them in Nigeria, committed to ensuring the overall eye health of the Nigerian child, and we are called NIPOSS. We are living in Nigeria, which is one of the 54 countries of Africa, and is the world's second largest and second most populous continent after Asia, which is about 1.3 billion people. And that is where I'm speaking from, with that brown arrow, that black arrow there in Nigeria, close to the west of Africa, in West Africa, near the Atlantic Ocean. In Nigeria, I'm speaking to you from Port Harcourt, and there are 36 states of the country. The capital is Abuja. We are over 208 million people by yesterday's estimate. And we have to take care of all this number of people, just about 40 pediatric ophthalmologists, which is just about 80% of the 500 ophthalmologists in the whole country. And we're working in about 21 centers across the country. And we have very busy clinics, as you can see. So we've been featuring these different topics for the last 2 years. So today we're talking about the management of this very important topic. We know it is one of the most common intraocular malignancies of childhood, and leukocoria is the most common form of presentation. It's important for us to just let you know briefly some of the challenges we have in Nigeria and other similar low-income countries. We have those associated with early presentation, delivery of care, acceptance of care, maintenance of care, and follow-up. So late presentation is generally a major issue in this part of the world, though it's getting better in the last few years, because we have better structure on ground and there's more synergy between the pediatric ophthalmologists and the oncologists. We're also beginning to have dedicated phone lines in some places with WhatsApp groups where we develop and discuss updates and different cases. Right now, we're developing a retinoblastoma register in the country where we're listing all the cases that we've had in the last few months. But in terms of delivery of care, in the 21 centers where children can be treated, precious few have the ability to offer all that is required. We have about less than 4 that have everything that is required to take care of these children. And that means we lack the basic equipment for treatment, especially equipment for transpupillary thermotherapy is very difficult to find. And radiotherapy also, very few centers have this, and therefore we have very long waiting lists. This is one of the cases of retinoblastoma that we have from time to time, very bad cases. And we have very few people to take good care of this one. So we'd rather just make sure that they present early. And this is one of the reasons why we have to talk about this. Now, in terms of accepting and financing care, the average cost per cycle in our centers could be up to like about $150, like 40 to 60,000 naira, which is way over the minimum wage. And after 1 or 2 cycles of spending this kind of money, a lot of people default. So, and when they have to have enucleation, less than a quarter actually accept it. So there's a very high default rate and non-completion of treatment as one of the major challenges. And so finance is a big challenge. We would like to have retinoblastoma centers. We've been advocating for that, but currently the government is not subsidizing medication, but we managed to add these drugs that retinoblastoma patients have to have into the National Essential Drug List. So they're actually available. The only thing is they're a little bit costly. So it's really up to us to determine that we're going to have a change. And this is one of the reasons why we're having this webinar. And it's not all green, actually, though it looks like it's been a green picture, but these patients we know can actually live and see well. We have a few patients who have actually done very well because of early diagnosis, careful handling. And in those centers, they have good therapeutic equipment. And if there is availability of appropriate medications in large quantities spread all over the centers, there will be better outcome. Radiotherapy is also important to have in at least every one of the 6 regions or geopolitical zones of the country. And with the presence of excellent counselors and social workers to follow up properly, we find that these patients can actually live and then see very well. So to help us to understand better how they were able to achieve this, we have a guest all the way from India who has gone through some of these teething problems that we are still going through, and is going to help us to understand how we're going to ensure that we are able to get better care for these ones. So our guest for this 4th quarterly webinar for this year is Dr. Swathi Kaliki. So in the past few years since then, her work experience has been mainly in LV Prasad. She's been working there as a consultant from 2013. She's also the head of service of the Institute for Eye Cancer from 2016 till now. And she's also the head of service currently of the Oculoplasty and Oncology service of the hospital since 2019. So help me welcome Swathi Kaliki as our guest today, speaking to us about management of retinoblastoma. You're welcome, Swathi. Thank you for joining us.
Thank you very much for that very kind introduction, Adedayo. So I'll be talking to you all a very warm welcome to everyone who have joined this webinar. So over the next 40 to 45 minutes, I'll be taking you over about retinoblastoma, talking about the basics of retinoblastoma and its management. Okay, so I hope all of you can see the slides. Just a brief historical perspective about retinoblastoma. So it has been described way back in 1597 by Peter Poyes. The clinical description of this was first in 1809 by James Wardrop. The terminology retinoblastoma was coined by Verhoeff in 1920s, and finally it was adopted by the American Ophthalmological Society in 1926. Since then onwards, we recognize the tumor by the terminology retinoblastoma. As you all know, retinoblastoma is the most common intraocular tumor in children. It's the 8th most common pediatric cancer, represents about 11% of cancers in the first year of life, overall about 3% of childhood cancers. And the retinoblastoma is mostly diagnosed before the age of 5 years in 95% of the cases. And the incidence is about 1 in 15,000 to 18,000 live births. Now, why is it important to know about retinoblastoma? Now, this is a very nice article that was published in BJO, I think in the year 2009, authored by Tero Kivela, where he spoke about how the mortality rates is different in different countries. So as we can see, it's a huge problem. There are about 7,000 to 8,000 new cases which are diagnosed every year across the globe. And 50% of them, they die every year due to retinoblastoma. And most of these deaths occur in the continents of Africa and Asia. The death rate is as high as 70% in Africa and being about 42% in Asia, while the mortality rates are very low in developed countries, where more than 95% of the cases are alive, free of disease, and they retain the vision as well. Now, in India specifically, it's one of the country where we have the highest number of cases, and probably that has also given us more experience to deal with these cancers. Now, why does retinoblastoma occur? It occurs because of genetic mutation in the RB1 gene, which is located on the chromosome 13. And I'm sure most of us are familiar about the Knutson's two-hit hypothesis. Now, if it is a hereditary retinoblastoma, then the child is born with a mutation in every cell. And after a second mutation occurs specifically in the retinal cell, that's when the retinoblastoma becomes apparent if it is a hereditary retinoblastoma. While if it is a non-hereditary retinoblastoma, they are not born with any mutation. Both the first and the second mutations, they occur after birth. resulting in retinoblastoma at a little later age when compared to that of hereditary retinoblastoma. So as we have spoken already, so it can be hereditary, which is seen in about 40% of the cases, or it can be sporadic, seen in about 60% of the cases. The hereditary pattern of retinoblastoma, it is associated with the germline mutation in all cells of the body, which means that they are at risk of developing second cancers elsewhere in the body. About 10% of them have a positive family history, while the rest of them do not have any family history. The tumors are bilateral in 90% of the cases, but in 10% of the cases, the tumors may be unilateral. And that is where genetic testing becomes important. And all patients with bilateral retinoblastoma, they have a hereditary form. That means they can transmit the disease to the next generation, with the risk of transmission being almost 50% to the offspring. Now, the sporadic or the somatic, which is a more common variety, is seen in about 60% of the cases, where the RB1 mutation, it occurs only in the retinal cells, which is why the chances of second cancers elsewhere in the body are less. And mostly it is always a unilateral disease, and it is not heritable. So it does not transmit to the next generations. Now, what is the clinical significance of this? That's the hereditary retinoblastoma, they occur at younger age. They're more likely to be bilateral and multifocal, and they have 6 to 10% lifelong risk of second cancers. While the sporadic variant, here the mean age at presentation is much later, and they're more likely to be unilateral and unifocal. Now, what is the importance of knowing the family history? Now, it is very important to ask specifically about family history, because we can assess what is the risk of transmission of this disease to the next generation, or even what is the chance of having this disease in the siblings. When there is a positive family history of retinoblastoma and the tumor is multifocal or unifocal or bilateral, then it means that the patient is carrying a germline mutation, and the risk of transmission to the offsprings is about 50%. If the family history is negative, then the risk of transmission, and the tumor is unilateral, the risk of transmission is only less than 5%. The chances of having the germline mutation, of course, is about 15%, which means that if they have a germline mutation, then the risk of transmission automatically increases to 50%. Now, as discussed, most of these cases, they occurred before 5 years of age, and the mean age at presentation is about 18 months. The tumor is mostly unilateral in about 75% of the cases. It can be bilateral in 25% or trilateral in 1%. That is trilateral where the tumor is present in both the eyes, and they also have the pineloblastoma. Now, the most common way that retinoblastoma presents is a white reflex in the eye, or also called as leukocoria, which is seen in about 60% of the cases. And strabismus is seen in about 20%. Here are examples where the child has presented with leukocoria. And these can be easily picked up on photographs, as can be seen in this child, where the white reflex was picked up during the first birthday pictures when they were taken. And then the child was brought in for an eye examination. Now, though we say as leukocoria, it is not strictly a white reflex. Sometimes the color may vary depending upon the tumor characteristics. Like in the first one, it appears more or less grayish white in color. The second one is more yellow. So xanthocoria is not always Coats disease. Sometimes when there is exudation along with retinoblastoma, they can give rise to a yellow reflex. Or it may be more pinkish, or it may be even greenish hue, like in the last picture when there is blood staining of the cornea. Sometimes they present as strabismus, where there is squinting of the eye, and most of the times whenever these children present with squint, they get detected with retinoblastoma much later, because it is often not done that fundus examination is done in every child who presents with squint. So it's very important to do a fundus examination of every child who comes to us with strabismus, so as not to miss the diagnosis of retinoblastoma. They can present as a red eye in advanced stages, like in these cases when it is much more advanced, where most of these children may go on to develop secondary glaucoma, resulting in congestion of the eye, or sometimes there may be blood in the anterior chamber, giving this appearance of a red eye. If these cases go on to an advanced stage, they can present with orbital pseudocellulitis, where there is inflammation of the orbital structures. That is when they present with cellulitis, and they should not be mistaken as the bacterial cellulitis, but these are non-infective cellulitis. Here is an example where the child presented with cellulitis, and unless we do a fundus examination or a B scan or a CT or MRI, the tumor which is present inside the eye may be missed. They can also present with pseudohypopion, that is the white, the sediment that may be present in the anterior chamber. And sometimes it may be anterior retinoblastoma, where only the anterior chamber may be involved, and the immediate ciliary body region and the retinal tumor may be completely absent in these cases. In very, very advanced stages, when the tumor outgrows the blood supply, then it can cause necrosis of the tumor, and the eye can become thysical. So in very advanced stages, the patients may come to us with phthisis bulbi. Or they can have orbital tumor extension, as can be seen in these cases, where the tumor has extended beyond the eye. In some cases, in neglected cases, they can even come with large fungating masses, as can be seen in these pictures. And why do they occur? It's mainly because they are neglected. They are not treated on time. Like here is an example of a child who presented with intraocular tumor in his left eye, but he did not he did not get the treatment on time, and he came back with extraocular extension of the tumor, where the tumor was extending along the optic nerve and subsequently to the brain. Here is another example where the first picture that you see, the patient had a pseudohypopion and a very advanced tumor, but and the child was advised enucleation. The child did not undergo enucleation, and after few months, the child came back with the picture that you see on the right, where there is extraocular extension and also involving the orbital, the bones of the forehead as well, where you can see the frontal bone bossing that is noted. Here is another example where the child had undergone exenteration but did not come for follow-up later, and the tumor has extended into the parotid gland and also into the long bones. Now, that is about the clinical presentation. Then moving on to classification. So the tumors can be, the intraocular tumors can be grouped. And when we talk about intraocular and extraocular tumors and the general status of the patient, that is when we call as staging of the disease. Now, grouping of the tumor can be, there are various classification systems that have been proposed, like the Rees-Ellsworth classification, SN classification, the International Classification of Retinoblastoma. The one which is quite famously used is the International Classification of Retinoblastoma, where it can be classified as Group A, the tumor being less than or equal to 3 millimeters, Group B, when the tumor is more than 3 millimeters or is associated with subretinal fluid, or if the tumor is present in the macula, Group C, when it is associated with localized subretinal or vitreous seeds, Group D, when it is associated with diffuse subretinal or vitreous seeds, and Group E, when it is very advanced tumor requiring enucleation. Now, staging of the disease, again, there are various staging classifications that have been proposed, but the most common one that is used is the International Retinoblastoma Staging System, where it can be classified as stage 0, where the globe salvage can be achieved. Stage 1, where the eye is enucleated, but there is no microscopic residue. Stage 2, when the eye is enucleated, but there is microscopic residue. Stage 3 being the orbital disease, and stage 4 being metastatic disease. Now, here are examples of stage 0, where when the patient presents with tumor such as this within an intraocular tumor, the globe can be salvaged. But when the patient presents with very advanced tumor, the globe may need to be enucleated, but there is no microscopic residue after enucleation of the eye. Stage 2 is when the globe is enucleated, but there is microscopic residue because of extraocular extension of the tumor. Stage 3A, where there is overt orbital extension, as can be seen in this child, there is optic nerve extension of the tumor. 3B, where the tumor has spread into, there is extraocular extension and the tumor has spread into the regional lymph nodes here. Stage 4A, where it has extended beyond the orbit, beyond, it has gone, the systemic metastasis has occurred, like can be seen here. And stage 4B, where the tumor has extended into the brain, that is when there is CNS extension. The cytology pictured below is the tumor cells which are present on CSF aspirate. Now, next, moving to the retinoblastoma management. Now, whenever we talk about managing a case of retinoblastoma, there are multiple things we need to consider. The tumor laterality, then the size of the tumor, whether there is involvement of the macula, whether it is associated with vitreous or subretinal seeding, whether after enucleation there are high-risk features, the age of the patient, the general health of the patient, family history, and of course, the desires of the family. So all these have to be taken into account whenever we manage a case of retinoblastoma. Now, there are various treatment options that are available for retinoblastoma, starting from focal treatment, which can be in the form of cryotherapy, transpupillary thermotherapy, or laser photocoagulation. Chemotherapy, which can be intravenous, intra-arterial, intravitreal, or subtenon's chemotherapy. Radiotherapy, where it can be external beam radiotherapy or plaque radiotherapy, or sometimes enucleation. Now we'll talk about each of these treatment options in the next few slides. Now going back to focal treatment. Starting with cryotherapy. Now cryotherapy, the use of cryotherapy was first reported in 1967 by Linkoff et al. And it is mostly used for tumors which are small, which means that the thickness of the tumor is not more than 3 millimeters, and they're located in the equator or in the periphery. And whenever we treat a case of retinoblastoma, we always do triple freeze-thaw cryotherapy, and each session may have to be repeated for every 4 to 6 weeks. Most of the tumors, they respond with 2 or 3 sessions, and some tumors may require more than 3 sessions. Now, here is an example where there is a tumor that is located at the equator. And if we do cryotherapy to this patient, this is what the patient will look like, where it can be seen that there is a scar in the area of previous tumor. Now, these are the various cryo probes that are available. Generally, we use the 15-degree curved probe for whenever we treat a case of retinoblastoma. This is the cryotherapy machine that is used. And the cryotherapy, it acts on the based on the principle of the Joule-Thomson or the Joule-Kelvin effect. Where there is rapid freezing of the tumor tissue, the temperature reaches minus 90 degrees. It results in a formation of intracellular ice crystal, resulting in protein denaturation, pH changes, and then the rupture of the cell, resulting in secondary thrombosis and infarction of tumor tissue. So that's the mechanism of action of cryotherapy on the tumor. Now, we also use the terminology what we call as chemocryotherapy. That means here, this is not a triple freeze-thaw cryotherapy that we do. We use single freeze-thaw cryotherapy. And this is usually done in combination with intravenous chemotherapy, usually about 24 hours before intravenous chemotherapy. When we do this breaks the blood-retinal barrier and helps in increased penetration of chemotherapeutic agents into the eye. Specifically carboplatin, where it has been shown that the amount of carboplatin that enters the eye after a chemocryotherapy is 15 folds more than otherwise. Next, moving to transpupillary thermotherapy. So transpupillary thermotherapy is a laser form of treatment where the laser is applied directly over the tumor. We use infrared diode laser with a wavelength of 810 nanometers. And this again should be used for tumors which are small in size, which are less than or equal to 3 millimeters in thickness. The location of the tumors here, it can be located in the equator or in the posterior pole. And whenever we do TTT or the transpupillary thermotherapy, the end point is we look for if there is graying of the tumor. And this again, similar to cryotherapy, it needs to be repeated every 4 to 6 weeks. And TTT again, usually the tumors respond in 2 to 3 sessions. Now, this is the transpupillary thermotherapy machine that we generally use, where the spot size is about 1.2 millimeters. The power that we use is 300 to 600 milliwatts. The duration of 9,000 milliseconds at an interval of 50 milliseconds. And generally, we limit the number of spots to less than 35 so that we are not, because whenever we have to remember that when we are doing TTT, the laser is passing through the lens. So excess laser to the lens again can cause cataract. So we have to keep in mind that we do not deliver this TTT for more than 5 to 7 minutes. Now, here is an example of transpupillary thermotherapy where there is a tumor which is present in the posterior pole. And if I apply TTT to this is what it will result in. So there will be a scar in the area of the tumor. Here, the advantage of TTT over cryotherapy is that the scar is not large. The scar will be exactly same as the tumor size. And that is why it is preferable for tumors which are present in the posterior pole. With transpupillary thermotherapy, it results in slow and sustained temperature. The temperature increases to 40 to 60 degrees and it causes direct cytotoxic effect on the tumor cells. Similar to chemocryotherapy, we also have thermochemotherapy, where we do TTT as a consolidation treatment prior to chemotherapy. Here again, the principle is the same. That is to break the blood retinal barrier so that there is increased uptake of carboplatin into the eye. The other form of focal treatment that is available is the argon laser photocoagulation. Here, instead of the diode laser, we can use the argon laser where the wavelength is 532 nanometers. Here, generally, we use about 350 to 500 milliwatts power for about 30 seconds. And this again is repeated every 4 to 6 weeks. Now, the difference between TTT and argon laser photocoagulation is that, as I mentioned, when we do TTT, we apply the spot directly on the tumor. But when we apply the argon laser photocoagulation, here the spots are applied around the tumor. We apply these 2 rows of laser around the tumor because the basic principle of the argon laser photocoagulation is it causes coagulation. That is, it cuts off the blood supply that is coming to the tumor. And that is why we do the laser around the tumor rather than over the tumor. That was about focal treatments. Next, moving on to chemotherapy. Now, first starting with intravenous chemotherapy. Now, intravenous chemotherapy, the drugs which have been shown effective for intravenous chemotherapy are vincristine, etoposide, and carboplatin. Generally, these chemotherapeutic agents are given over 2 days. We call it as day 0 and day 1. Day 0, where all 3 drugs are given, and on day 1, only etoposide is given. And usually, most of the cases require a total of 6 cycles of chemotherapy. Now, we have something called a standard dose and high dose chemotherapy. I think this is something that is important to know. The standard dose chemotherapy, the dose of the drugs is slightly on the lower side when compared to that of high dose chemotherapy, especially where the etoposide and carboplatin doses are higher with high dose chemotherapy. Standard dose chemotherapy is preferred for intraocular tumors, while high dose chemotherapy is used when the tumor has extended beyond the eye. That is whenever there is extraocular extension, or sometimes even when there is advanced intraocular tumor in both the eyes, then we use high dose chemotherapy. Now, here are examples of intraocular tumor which have been treated with standard dose chemotherapy. And as you can see, the tumors have responded really well with intravenous chemotherapy. Here is another example where there are large tumors which are present within the eye and chemotherapy has been given to them and the tumors have completely regressed. That is the intravenous chemotherapy. Next, moving on to periocular chemotherapy. Now, periocular chemotherapy, generally we used to use the subtenon's carboplatin at a dose of 20 milligram per 2 cc. Yeah. Now, this is very rarely used now because of now we use intravitreal chemotherapy. So carboplatin is the subtenon's carboplatin is rarely used. But here is an example where subtenon's carboplatin was used in this patient. So this is a patient with an endophytic tumor before chemotherapy, and after chemotherapy you can see that there are diffuse vitreous seeds, and for these patients carboplatin was used, and you can see that the tumor has nicely regressed and the vitreous seeds have completely regressed because of the subtenon's carboplatin. Now, next, moving to intra-arterial chemotherapy. Now, intra-arterial chemotherapy is where the chemotherapy is delivered to the eye directly. So here we pass a catheter from the femoral artery go along the aorta, along the arch of aorta, then enter the common carotid artery and then the internal carotid artery. And once we enter the internal carotid artery, the first branch that arises from the internal carotid artery is the ophthalmic artery. So we reach till the ophthalmic artery, and then the chemotherapeutic agent is delivered. We generally use melphalan, even carboplatin and topotecan are the drugs which are used for intra-arterial chemotherapy. And these drugs, they directly enter into the eye. Now, here is an example where we have used intra-arterial chemotherapy. Now, this is a patient who has failed treatment with intravenous chemotherapy, where the child has received 14 cycles of intravenous chemotherapy, and then intra-arterial chemotherapy was given to this patient. And you can see that the tumor has very nicely regressed with intra-arterial chemotherapy. Now, intra-arterial chemotherapy, it can be used either as primary treatment or as secondary treatment when other forms of treatments fail. Now, next, moving to intravitreal chemotherapy. Now, this is a very important paper that was published by the Switzerland group, where they showed that intravitreal chemotherapy is effective for retinoblastoma. Now, they had included all the eyes which had failed all other forms of treatment. They gave melphalan of 20 to 30 microgram per 0.1 cc. About 122 injections were given in these patients, and they noted that there was no evidence of extraocular extension when we do intravitreal chemotherapy. And globe salvage was achieved in 87% of the cases over 2 years follow-up. The only side effect that they noted was that there is RPE mottling near injection site. So intravitreal chemotherapy is a very good form of treatment for whenever there are vitreous seeds, but we should understand that it has to be given very, very carefully, because a wrong technique can result in extraocular extension of the tumor, resulting in mortality of the child. So knowing the technique correctly is very, very important whenever we are doing intravitreal chemotherapy. Now, here is an example when we have done intravitreal chemotherapy. So this is a patient who had an endophytic tumor with vitreous seeds, and this tumor really did not respond very well after 6 cycles of chemotherapy. So we gave the patient another 6 cycles of chemotherapy, but the vitreous seeds were just not going away. And so in this patient, we again restarted systemic chemotherapy, and we also gave adjuvant periocular carboplatin, but it really didn't help. So that is, so this is after the first cycle of chemo along with periocular carboplatin. And there's again, second cycle of carboplatin was given, and it still didn't help. Then we gave external beam radiotherapy to this patient. It still didn't help. And this is when, this is the patient where we have tried all forms of treatment and the patient still had these vitreous seeds. That's when we gave intravitreal chemotherapy to this patient, and this patient responded really well after intravitreal chemotherapy. Now, intravitreal chemotherapy, here is another example where you can say, so the vitreous seeds, there are basically 3 types of vitreous seeds. That is, it can be dust, where there are fine particles of vitreous seeds. There can be sperules, like here, where there are well-defined large vitreous seeds, or they can be cloud. That is the previous case where you have seen where there is cloud of vitreous seeds. Now, in these cases, when we can give intravitreal chemotherapy, it really helps the vitreous seeds. Now, this is another case where we gave systemic chemotherapy for this patient, but the patient had these vitreous seeds which were just not going away with systemic chemotherapy. That's when we gave intravitreal chemotherapy for this patient. And you can see that with each intravitreal injection, the tumors, the seeds completely went away, but you can also note that it has caused some toxic effects on the retina. So intravitreal chemotherapy is not free of complications. It can have side effects as well. And these side effects are mostly seen when you give melphalan. So now we have slowly shifted to giving intravitreal topotecan, and we have seen that the side effects with topotecan is much less when compared to that of intravitreal melphalan. And these are given usually every 3 to 4 weeks. And most of these cases require treatment for almost about 6 to 8 months. Now, the technique of intravitreal chemotherapy is that you give it through the pars plana route. So you identify the pars plana. So we have to understand that in children, the pars plana will not be present at 4 millimeters. It depends on the age of the child. If the child is only 2 years of age, the pars plana will be 2 millimeters away from the limbus. If the child is 3 years, it will be 3 millimeters away. If the child is 4 years or more, then it will be 4 millimeters away from the limbus. So we give the injection in the pars plana, and once it is given, the most important step, so and also the correct site should be chosen. So it should not be an area where there are active vitreous seeds. So generally we choose a claw cover where there are no vitreous seeds, such that we are not causing the vitreous seeds to come out of the eye when we are taking out the needle. Now, the important step when we do intravitreal chemotherapy is that we have to do cryotherapy at the site of injection even before the needle is withdrawn from the eye. So that is what is being done in this case. And then we complete the triple freeze thaw cryo at the site of injection. And after that, we just shake the eye a little bit so that the drug disperses within the eye. And then we give a thorough wash with saline so that even if there is any extraocular extension, that is washed away. And that's how the intravitreal chemotherapy is done. Now, next, moving to radiotherapy. Now, radiotherapy can be external beam radiotherapy or plaque radiotherapy. Now, external beam radiotherapy is very rarely used nowadays because we have other forms of treatment, especially the intravitreal chemotherapy. But here is an example where this patient was not responding to systemic chemotherapy, and then radiotherapy was done, and then the child showed very good response. The other form of radiotherapy that can be done is the plaque radiotherapy. These are the ruthenium plaques that we generally use. The above one is a notch plaque and the below one is a round plaque. So it can be done as primary treatment or secondary treatment when other treatments fail. And usually the amount of radiation that we give is 40 gray to tumor apex. Now, here is an example where the patient has received multiple forms of treatment, but still there are areas of tumor which are active. So we do plaque radiotherapy for these patients, and you can see that the tumors nicely regress after plaque radiotherapy. Here is another example where the tumor is active after multiple forms of treatment. We again did radiotherapy for this patient, and the tumor nicely regressed with radiotherapy. Now, it can also be used for subretinal seeds such as this, where the subretinal seeds are present in the periphery, not responding to cryotherapy. In such cases, we can do plaque, and you can see that the tumor nicely regresses after radiation treatment in such cases. Now, last, coming to enucleation. Now, enucleation is performed when the tumor is very advanced and there is no extraocular extension of the tumor. So that is one thing to remember, that whenever there is extraocular extension of the tumor, please do not do primary enucleation. It has to be done only when the tumor is limited to the eye. Now, the technique of enucleation is shown in this video. So first, an eyelid speculum is applied, and if needed, a small canthotomy, cantholysis can be done if you feel that there is not enough space to do enucleation. Then 360 degrees peritomy is done. Save as much as conjunctiva as possible, and then a tenotomy is done. You open up the tenons on all 4 quadrants, and once that is done, then the extraocular muscles are hooked. This is the medial. So we always start with the muscle which is closest to the limbus. That's the medial rectus. So first, a traction suture is placed with any suture. It can be absorbable or non-absorbable. And then about 4 to 5 millimeters away from the suture, we put a tag suture. This we use absorbable suture. And then the muzzle is cut in between. So this is done for in the order of first the medial rectus, then the inferior rectus, then the lateral rectus and the superior rectus, based on the distance of these muscles from the limbus. So now the 2 muscles have been cut. The third, all the 4 recti muscles have been cut. And then the oblique muscle, this is the superior oblique. Now this muscle, we simply cut it. We do not reattach it. And this is the inferior oblique muscle. And same thing even for the inferior oblique muscle, we do not reattach the muscle. So we simply cut the muscle. Once this is done, the globe is prolapsed out of the globe. The optic nerve is trumped till the apex, and then the optic nerve should be cut in one single cut. No hesitant cuts should be given, and then the globe is removed. Once this is done, we always examine the globe to see if there is any extraocular extension, the length of the optic nerve. And then this is the posterior tenons. We hold the posterior tenons and put an adequate sized implant in the intraconal space. Then the posterior tenons is sutured with an absorbable suture, where here we are using a 6-0 vicryl suture. The posterior tenons is sutured well. And once the posterior tenons is sutured, here comes the important step where we will do the myoconjunctival technique. For this, the extraocular muscles, the tag sutures that are there for the extraocular muscles, these are exteriorized. So these are the extraocular muscle sutures where we are putting a free needle and then bringing them out via the conjunctiva at the phonesis, where we will be attaching the muscles there. And then the anterior tenons is then closed. After the anterior tenons is closed, and then we close the conjunctiva. So basically, it is a three-layered closure. First is the posterior tenons, second is the anterior tenons, and then third is the conjunctiva. So that's a conjunctiva being closed. And once the conjunctiva is closed, then it is important to place a conformer. So that's a conformer which is being placed in the eye, because if we do not place a conformer correctly, then putting a prosthesis for the patient is going to be difficult. And then we close the eyelid by doing a suture tarsorrhaphy, which is removed after 1 week. This is the suture tarsorrhaphy that is being done. So that's what we do for very advanced tumors. Now, what do we do for such tumors where there is extraocular extension? As I mentioned, whenever the tumor is extending outside the eye, please do not do enucleation or exenteration as a primary procedure. You have to first chemo reduce and then do the procedure. So the protocol that is used for tumors which have extended beyond the orbit is this, what is shown here. That is, first give 6 cycles of high dose chemotherapy, and then you will see that the globe will become thicical, and then you go ahead and do enucleation of that eye, followed by external beam radiotherapy, where you deliver about 35 to 40 gray of radiation to the socket, and then complete 6 more cycles of high dose chemotherapy. So in total, we are going to give 12 cycles of high dose chemotherapy, and sandwich treatment of enucleation and external beam radiotherapy is done in between. This is how we treat whenever there is extraocular extension of the tumor. Now, here is an example where you can see that the tumor is extending into the optic nerve. And after chemotherapy, this is what happens when the globe has become thicical, and even the optic nerve looks much thinner when compared to what it was before. And at this stage, you go ahead and do enucleation and radiation, and then complete another 6 cycles of chemotherapy. Here is the next case where there is obvious extraocular extension that is present. Look at what happens after 6 cycles of chemotherapy. You can see that the globe has become nicely thicical, where you can go ahead and remove the eye and then follow it up with radiation and further 6 cycles of chemotherapy. And it has dramatic effect even in such cases where there is extensive extraocular extension. You can see that here again, the larger the tumor, better is the effect, where it just shrinks. Even after the first cycle itself, you can see the changes. And once, if after chemotherapy there is still extraocular extension, only then you do orbital exenteration. So 99% of the cases, even if the eye needs to be removed, enucleation is sufficient. You do not need orbital exenteration. Orbital exenteration is only done if there is residual tumor in the extraocular space in spite of chemotherapy. And as I mentioned, please do not do primary enucleation or exenteration in such cases. And after enucleation, then you go ahead and do a customized ocular prosthesis, like in this case, where a customized ocular prosthesis can be placed after 6 weeks of enucleation in such cases. So that is how we manage the cases of retinoblastoma. So with this, I end my talk. I think we have sufficient time for questions. I'll be happy to take any questions.
Consanguinity and retinoblastoma. What do you think about consanguinity and retinoblastoma?
Yeah, so whenever it is consanguineous marriages, it results in autosomal recessive diseases. But retinoblastoma is an autosomal dominant transmission. So consanguinity really shouldn't influence the transmission for retinoblastoma. It's just that if there is a family history of retinoblastoma, then of course, because it is autosomal dominant transmission, then the risk of transmission is as high as 50%. So the first question, for second time intravenous chemo for recurrent or resistant tumor, do you use same VEC regime or change regimen? Yeah, unfortunately for retinoblastoma, we do not have an effective second line chemotherapy drugs. VEC, that's vincristine, etoposide, and carboplatin, are the drugs which have been shown to be effective for RB cases. So in these cases, if there is tumor recurrence after completion of chemotherapy, you can give second round of the same VEC drugs. The other drugs, really, they do, the cyclophosphamide, of course, can be used, but these three drugs are more effective. So if VEC drugs do not help, then we have to think of intra-arterial chemotherapy. I understand that intra-arterial chemotherapy may be a challenge in many countries. In such cases, then changing to high-dose chemotherapy is another option. Now, the next question
What about intrathecal? What about intrathecal? Do you believe in intrathecal chemo?
Intrathecal chemotherapy we used to do whenever there is intracranial extension. That is when the CSF metastasis has already occurred. We used to do intrathecal chemotherapy in these cases, but the mortality rate is extremely high once it has gone into the CNS. Whatever treatment we do, it's the mortality is happens. But of course, we can prolong life in these cases by giving intrathecal chemotherapy. So intrathecal chemotherapy is reserved for cases where there is intracranial extension. Okay, so the next question is, can you tell differential diagnosis of leukocoria? So there is a whole list of differentials for leukocoria, the most common being Coates disease. So you have to rule out Coates disease. There will be lots of exudation that will be present, and there will be peripheral retinal telangiectasia. So that helps us in the diagnosis of Coates disease. The ROP obviously will not have an intraocular mass with calcification, whereas in retinoblastoma, there will be an intraocular mass. And then the other differentials can be familial exudative vitreoretinopathy that can occur. This again, you have to thoroughly examine the eye where FEVR obviously is bilateral, and the families may also have it. So all these kind of help you to differentiate retinoblastoma from other conditions causing leukocoria. Okay, the third question is, in case of routine fundus examination of a child with squint, any specific things to look out for to rule out RB? So whenever we are seeing a child with squint, fundus examination, when you do, you have to look for if there is any tumor, intraocular tumor that is present. Most of the cases, it should not be difficult because whenever there is a squint because of retinoblastoma, it's because the tumor is present in the posterior pole. So it is really easy to diagnose a case of retinoblastoma whenever it is presenting with squint. It just needs a fundus examination. If necessary, I think we should not hesitate to take the child under anesthesia and examine the child.
Yes.
The next question is, are there any contraindications for intravitreal chemotherapy? Yes, intravitreal chemotherapy, it helps mainly for the vitreous seeds. It is not a replacement for intravenous chemotherapy because it is not much helpful for a solid tumor, though it may have some effect on the solid tumor and subretinal seeds, but intravitreal chemotherapy is mainly for vitreous seeds. Now, the other contraindication is that if it is diffuse, if the eye is completely filled with vitreous seeds where there is no, area where there are no vitreous seeds, it is not safe to go in with the needle. So you need to have at least one clock hour where there are no vitreous seeds for you to go in and inject the chemotherapy into the eye. So that was about the contraindications for intravitreal chemo. The next question is, histopathology reported tumor extension to 18 millimeters of 21 millimeters optic nerve. Would you advise high dose or standard chemotherapy, as a child was classified as intraocular disease? Yeah, so if the optic nerve transection is free, which is what I understand it is, because you have put as that the optic nerve stump was 21 millimeters, which is very good. And the optic nerve extension was 18 millimeters, which means that the optic nerve cut end is free of tumor. In such cases, you can give standard dose chemotherapy, 6 cycles is sufficient. If there was the optic nerve cut end is involved, or if there is extraocular extension, extrascleral extension, that is if the outer layers of the sclera are involved, then you have to treat it as with 12 cycles of high dose chemo and also radiation. But otherwise, you do not need radiation and 12 cycles of chemo. The next question, any experience with prophylactic external beam radiotherapy to regressed D or E in residual eye to prevent recurrence. Yeah, we do not give prophylactic external beam radiotherapy, but yes, there has been at least one publication where they have given chemotherapy and a prophylactic EBRT, and they've shown that the chances of tumor recurrence is low. But in this day and age, it is always better to avoid external beam radiotherapy whenever possible. So we do not give external beam radiotherapy unless it is really required, as in if there is extraocular extension of the tumor, or if it is the only eye and all other forms of treatment have failed, only then we give external beam radiotherapy. Otherwise, we do not. The next question is, what do we do for unilateral retinoblastoma group D with vitreous seeding? We do not have modalities such as melphalan or topotecan intravitreal. Okay, so when the intravitreal option is not available, then I think, of course, we have then the limited choices of only intravenous chemotherapy. But having said that, I think I don't know how difficult it is to get. Melphalan is maybe a little difficult to get, but topotecan should be easy to procure. So if you can get hold of topotecan, then I think you can start giving intravitreal. But as I said, you have to be well versed with the technique and do it the correct way, so as not to cause any iatrogenic complications in these patients. But if intravitreal is just not possible, then I think the only modality of treatment that can be tried is intravenous chemotherapy. Okay, the next question is, how do we determine whether we start intra-arterial or systemic chemotherapy? Yeah, if it is bilateral tumor, then it is better to give intravenous chemotherapy. If it is unilateral tumor, then you can always give an option of intravenous or intra-arterial chemotherapy. Intra-arterial chemotherapy is a very good option as a primary treatment if it is a unilateral disease. The next question is, if a patient has RB in one eye, how should we screen the other eye? How often and for how many years? Okay, so the standard protocol that we follow is the first year, like whenever we see the patient first, if we are giving chemotherapy, we see the patient every 3 weeks. After completion of chemotherapy and the tumor has completely regressed, then we see the patient once in 3 months in the first year, once in 4 months the second year, once in 6 months the third year, and thereafter we see the patient once a year for life. So we always explain to the patient that the follow-up for RB is very important. We have to, even if the other eye is normal, we still have to examine the eye. But if you have the facility to do genetic testing, and if you know that it is not germline mutation, then probably you do not need lifelong follow-up. If it is germline mutation, you need lifelong follow-up because you have to also monitor them for second cancers. But if it is a somatic mutation, it is not a germline mutation. In such cases, you can examine the child till 5 years of age, and thereafter you really don't have to examine if it is a somatic mutation. What are the investigations to be done before and in the course of chemotherapy, and your experience with side effects of this chemotherapy? Okay, the investigations that we do for every patient of retinoblastoma is orbital imaging. Preferably MRI should be done because CT again causes radiation exposure. So CT, if it can be avoided, it should be. MRI is preferable. If you do not have access to MRI, then CT should be done. The reason that why do we do CT is, especially if it is germline mutation, we have to rule out pinealoblastoma. So that is why CT is important. Now during chemotherapy, it is just the blood investigations that are required. We do not need any imaging, just the blood investigations. Just to see if they have if they have pancytopenia, the investigations would be needed. The side effects for with chemotherapy, yes, they do cause side effects, but these are it is important to counsel the parents that these are temporary. These are present only when the child is getting chemotherapy, and after completion of chemotherapy, the children will do okay. So the side effects, of course, these are the common side effects like hair loss, vomiting, weight loss, and the child not able to eat properly, metallic taste. All these are the common side effects that we see, and we have to just monitor the patients. And of course, the pancytopenia may occur, and they may require repeated blood transfusions. but they generally do after well after chemotherapy. It is extremely rare, though there have been side effects of leukemia that has been reported, but these are very, very rare side effects. Can intravitreal chemotherapy itself cause vitreous seeding during injection? That's the next question. So if the intravitreal chemotherapy is done in the right technique, it will not cause seeding. So that is why knowing the technique properly is important before the technique is started. Okay, then next question is, where do you attach extraocular muscles after enucleation? So the extraocular muscles, if we are doing the myoconjunctival technique, the extraocular muscles are attached to the conjunctiva. So you saw that there will be tag sutures. The tag sutures are taken out through the conjunctiva and you tie them there. So you tie it to the conjunctival phonesis. The next question is, I have a patient with bilateral RB, right eye is advanced stage, and I plan to do enucleation after 2 cycles of chemo. Left eye has stage B tumor, but measures more than 3 millimeters. It's about 10 millimeters situated inferiorly. Which focal treatment should be attempted, cryo or TTT? Okay. So if you're doing enucleation for one eye after 2 cycles of chemo, one important point here is that if chemotherapy started before enucleation, please make sure to complete 6 cycles of chemotherapy. That means if, say, you're doing 2 cycles of chemotherapy before enucleation, please complete the remaining 4 cycles even after enucleation, even if your the histopathology does not show high risk features, because the histopathology that you get after chemotherapy will not give the true picture, and that is why it is important to complete the 6 cycles of chemotherapy. Then about the second part of the question, whether to use TTT or cryo, it depends on the exact location of the tumor. If it is present in the anterior portion, then you use cryotherapy. If it is present in the equator or the posterior pole, you use TTT. Okay, the next question is can retinoblastoma occur in another child from parents who are not relevant? Father has EBV and CMV when his wife was pregnant. If it is a germline mutation, then the sibling does have a chance, but otherwise, no, it doesn't. Now, in case of, the next question is, in case of orbital inflammation, is it necessary to give systemic corticosteroid to relieve inflammation? Yes. So if the patient has orbital pseudocellulitis, then we give 48 hours of intravenous steroids to these patients. We do not have to give antibiotics, just give steroids. The inflammation reduces, and then you go ahead with the routine treatment of retinoblastoma. So the next question is chemotherapy management in conjunction with oncologist? Yes. So always a medical oncologist should be part of your team. I think RB management, it requires a team of ophthalmologist, a medical oncologist, and a radiation oncologist whenever possible. So they should be part of your team as well. The next question is, what is the survival rate of a child with intracranial extension? Yeah, in our practice, the mortality rate is almost certain in all cases who have intracranial extension. The only with treatment we may possibly delay the death, but we may not be able to prevent death. So that is why it is important to diagnose the cases early, so that we do not get the cases when there is already extraocular, when there is intracranial extension. A child with intraocular disease, the survival rate is almost 95%. A child with extraocular disease, the survival rate is about 70%. A child with intracranial disease, the survival rate is less than 5%. That's the reality. So once the intracranial extension is there, high chances of death. Okay, so the next question is, can you tell us more about anterior chamber RB without a posterior segment mass? Yeah, so there is a variant called as anterior retinoblastoma, where there is the patient presents with pseudohypopion, and there would be tumor that would be present in the ciliary body and the iris area. This could be because of the development of the eye. There could be the abnormal cells with the mutation that may be present in this area, while the retinal cells are normal. So there will not be retinal tumor, but there would be pseudohypopion. So that is why whenever you see a pseudohypopion in a white eye, that means if the patient has a pseudohypopion without any conjunctival congestion, always keep in mind, and if it is a child, always keep in mind that it could be retinoblastoma. If there is pseudohypopion and there is conjunctival congestion and other signs of endophthalmitis, then of course it could be endophthalmitis. But if it is a white eye and pseudohypopion, please rule out retinoblastoma. And how do you rule out? This can be done by, you can just do a FNAC from the pseudohypopion. You do an anterior chamber tap, do it in a clear cornea, through the clear cornea. And once you do the tap, you do cryotherapy at the site of needle entry, just so that if there are any tumor cells, it is taken care of by cryotherapy. And these cells that you have taken from the anterior chamber, please send it for cytology. And if it confirms the diagnosis of retinoblastoma, then you have to treat it as retinoblastoma, where you may have to give systemic chemotherapy or sometimes enucleate the eye or sometimes do plaque radiotherapy. If not, if it is just infective cause, then of course you treat it as endophthalmitis. The next question is, how many cases of retinoblastoma in your country and what do you do for early diagnosis? Yeah, so the estimate has shown that there are about 1,000 to 1,500 new cases of retinoblastoma every year in India. At LVPI, we see about 250 to 300 cases a year. A lot of work has gone into increasing awareness about retinoblastoma, increasing awareness among general public by using the mass communication methods like newspapers and TV, radio, and we also do activities to involve the public. We also do a retinoblastoma awareness run, which kind of gets people involved in such activities, and we educate the school teachers, the pediatricians. So I think it's a lot of effort that needs to be put into increase awareness about retinoblastoma. Like, I may talk to you about very good globe salvage rates and very good survival rates, but unless there is good awareness about retinoblastoma, the cases they do not come into us in early stages, then it becomes very difficult to treat such cases. So I think the first step always has to be about increasing awareness about retinoblastoma.
And thank you so much, Swathi. I'm sure we can call on you next time, right? If we want to talk about it. We can never stop talking about retinoblastoma because it's always there with us. And we have many patients from all over the world. And I'm so happy that Swathi was able to join us again. Thank you so much, Swathi.